Our next set of two presentations focuses on surgery for breast cancer, and our first presentation is by Dr. Kaufman from University of Washington, presenting on increasing rates of mastectomy. Has the pendulum swung back?
Great. Thank you to the moderators and the SSO for allowing me to present our data. I have no disclosures. Use of mastectomy for early-stage breast cancer. In 1991, the NIH Consensus Conference stated that breast-conserving surgery was preferred because it provides survival rates equivalent to those of total mastectomy with axillary dissection at the time, while preserving the breast. Yet in 2009, Dr. Charlie Cox and others reported an unexplained 33% increase in the mastectomy rate for women with early breast cancer, and we've seen this across the country. It was really unclear what was driving that change, and many of these mastectomies were not really indicated by classic clinical factors. There are several potential causes that have been looked into as far as what's causing the increasing rate of mastectomy. The increase in use of breast MRI with suspected second lesions, increase in use of genetic testing for those with a family history, improvements in reconstruction techniques such as nipple-sparing mastectomy, which have made mastectomy less disfiguring, and more attractive, and also the increase in use of the internet and social media providing the so-called trending healthcare choices. The National Quality Measures for Breast Centers is a quality program from the National Consortium of Breast Centers that has about 800 members. Since 2005, the NQMBC has monitored the process of several processes of care provided by breast centers in a web-based voluntary program. Each center signs up by providing their own demographic data, such as geographic location, the volume of cancers they see, mammography volume, size of their city, etc. And we've monitored the submissions of this program for the last 10 years, 2005 to 2016. There are 31 quality measures. Each breast center answers each of the measures by providing an average performance of that particular measure based on a minimum of 30 consecutive patients for each measure. Submissions are not individual patient responses, but the average performance of the breast center for that particular measure covering a 6-month time period. Submissions are voluntary, and not every center submits every 6 months, but centers can stop and start also at will. This is a voluntary program. One of the 31 measures asks for the average use of breast-conserving surgery, and the flip side of that is the mastectomy for stage 1 and 2 invasive breast cancer. After submission, the results are added to the database and immediately available to compare one's performance with others who've answered that particular measure. Comparison can be in aggregate or serially over time. They can be filtered by the demographic data as mentioned below. There's an immediate integration of the data that's submitted now into the data set, which allows rapid knowledge of the trends of care. So the database is continuously updated. This is just an example of the 31 measures, of which I'm going to be talking about one, which is the breast conservation rate, and the flip side of that is the submission is either breast conservation rate or mastectomy. Those are the only two choices. For that particular measure, these are the submissions that have occurred. What you see in orange, and with the y-axis on the left, is the number of centers or the number of submissions by centers for that year. For example, in 2011, there were 138 submissions representing the blue line, which is 5,757 patients that were used to calculate those average responses. Overall, there were 1,100 submissions, averaging 43 patients per submission, about 39,000 patients. This is what we found. What we found is that we, just like Dr. Cox's paper, we saw a significant increase in the use of mastectomy if we use a baseline of 2005 and 6. We saw by 2008 that there was a 30% increase. And when you look at this graph, you can see what we would call the baseline rate of mastectomy percentage. But then after that rise, that it plateaued over time. There was this plateau between 2008 and 2012. But also, interestingly, most recently, it's gone down. And so there's a significant rise, a significant decrease, but there's been no difference between the baseline level between 2005 and 6 and current data through 2014 and 15. We also looked to see, is there some relationship between breast centers by their geographic region, the size of the city, mammography volume, or cancer volume per year. Subset analysis, really, there were probably two small numbers. We haven't really done the subset analysis, but these are the graphs looking at the United States split into 4 groups, looking at the size of the city. Again, you see the same general curve of a peak in the middle and slightly lower on either end, cancer volume. On the other hand, we looked at some other factors. We looked to see what things that have been discussed in the past. We looked at improvements in reconstructive techniques. Maybe that has something to do with it, or genetic testing, or breast MRI, and the increase in use of the internet and social media, as mentioned earlier. So if we try to take some national figures of, for example, the use of breast reconstruction, this happens to be from the American Society of Plastic and Reconstructive Surgeons, we saw that yes, the increase in reconstruction did parallel the increase in mastectomy rate. But the use of reconstruction has continued to increase and would not explain why the mastectomy rate actually has gone back down. We looked at genetic testing. Likewise, genetic testing has gone up, and there is a peak at the beginning of this rise. But like the previous study example, genetic testing has continued to be used, and the little drop on the top there is really related to many other companies coming into the field. Likewise, breast MRI. We all know that these factors probably do have some contribution to the increased rate. But the question is, why has it gone back down, if you believe our data, which I do? And the use of breast MRI has not gone down, although the rate of mastectomy has. Likewise, I don't know if you know that Facebook started in 2004, but the social media, use of social media, we all know that the use of social media has dramatically increased over the years, and there was a tremendous spike coincident with these other measures I've just shown you, the other variables at the beginning of this, but social media has only grown. It's never looked back. So how do we understand, what can we make, what connection can we make? One of the things that has changed in those 4 programs is not that the internet is used less, but maybe we don't interpret the internet as well as we did before. 2009 Harris poll suggested that 85% of people who use the internet felt the information is reliable. 85% in 2009, yet in 2016, 30% of people said they would trust some information, and only 4% of people would trust a lot of the information. So even though the use of social media has not changed, the trust in social media seems to have paralleled this decrease, and those are the years, although not exactly the numbers there, but those are years 2009 versus 2016, where the trust has gone from 85% to 30%. There are limitations in our study. It's not population-based. It uses aggregate averages, not individual patients for submission. It may not be representative of the entire country because only programs that feel they are high performers will participate in this NQMBC database. On the other hand, the results have demonstrated consistency over time across all collected variables, and we do perform random audits. So in summary, the NQMBC quality program has found significant rise in the use of mastectomy for stage 1 and 2 invasive breast cancer after 2006. The percent use of mastectomy rose, it plateaued, and then it returned to baseline rates after 2013. The NQMBC database may reveal trends not yet seen by other databases, which, due to the real-time current nature of our database, we cannot correlate individual breast center characteristics as a cause of these changes. Potential causal relationships include breast reconstruction, gene testing, breast MRI, and use of social media, which all probably have a role to play, at least in the rise. Initial confidence in social media followed by the lack of trust may relate to the return to baseline levels of mastectomy, and further studies should occur to examine these associations.